Hey, welcome to Lab Sherry. We are coming to the last two episodes of the Pitt Season 1. Last week was completely dramatic and chaotic, so let's see what's the story of this week's show.
Right. Well, I got some good news. County Public Health is sending in a truckload of supplies from McGee Women's and Mercy.
Gloria, we're gonna have to call in more blood donors.
Already done.
Donated. I don't. My blood needles.
Choppers are coming from blood banks in Erie and Youngstown.
Oh, thank God.
I appreciate the way you've handled logistics today.
Wait, hold on. What does she mean? More blood donors? You didn't use unscreened blood donations, did you?
We did what we had to do to save as many.
Well, in fact, in a real-life mass casualty event, the blood bank would be calling the nearby hospital the second they receive a message saying we have the event happening and the patients are on the way. They won't be waiting until 2 hours later, like right now. And the sequence is usually calling the hospitals that in-network. Sometimes the big level 1 trauma center hospitals, they are in a large health network and they would try to call every single smaller hospitals that are also in the network but are not in response for this mass casualty event. They were trying to get their blood product first. And the next thing they will do is calling all the other hospitals that are nearby but might be not in their health network, which does add a little bit barrier since they are not inside the same health service network, but nobody would be saying, I'm not willing to help you. And the third group they would call is the local Red Cross and the large Red Cross nearby, which is a helicopter delivery in this show. It's not going to be like all your supporting blood resources are coming in all at the end of the 2 hours later. It's going to be like a 10 to 20 minutes after we receive the mass casualty pager alarm. We'll be having a group of blood coming from nearby hospitals, and then maybe 30 to 1 hour later, it'll be coming from nearby Red Cross or the helicopter Red Cross. It is very unlikely in a real life mass casualty event you have to wait 2 to 3 hours to get the extra blood product for your response, which is a good thing.
Pulse ox is still 85 on high flow oxygen. BP is borderline.
What else, Dr. Santos?
Hemoglobinopathies.
Excellent.
Blood is chocolate brown.
Santos.
Methemoglobinemia.
Bingo.
It's funny that she just like hold a blood tube and then being like, oh, this is chocolate brown. It's gonna be a little bit hard to tell if it's just very dark blood or chocolate brown blood for a blood that is definitely severely deoxygenated because the color was so dark. A easier way to tell would be actually grab one of the tissues or a cloth or whatever you have at the hand and just make sure it's white and absorbent, and either give yourself a little finger stick or find a normal tube of blood. I personally just give myself a needle stick if I have to. It's just much easier because I know I'm healthy. And then you just tap it right onto the cloth and then put the patient's blood right next to it. And then after a few minutes, you will see a very clear difference in between the color. One will be red and getting darker, and another one will be very chocolatey. And this is gonna be a little bit disgusting, but girls in front of this camera, if you ever take a close look at your period blood at the end of your period, like day 5 or day 6, that leftovers that becomes brown and chocolatey, it'll be kind of close to that color.
Dilated right atrium and right ventricle. Right-sided strain with bowing of the septum.
Sounds like a PE. You throw a clot from having the tourniquet on?
Way too soon for a DVT. Okay, let's get him in left lateral decubitus. 1, 2. Van Dellenberg, ASAP.
What for?
Intracardiac air embolism, all that running around introduced air into the femoral vein right up to the heart. Now it's blocking blood flow to the lungs.
Need a CT to confirm.
They still backed up with other patients.
Well, maybe the cath lab can take them. They have fluoro. I'll go check.
Yeah, good luck with that.
Not for this case. Obviously, this case is not a pulmonary embolism or deep vein thrombosis. In this show, this guy is having air in his heart. In real life, if you have suspicions for people who might be having PE or DVT and need a CT confirmation, but you have to wait, there are always 2 tests you can order first for at least rule things out. One of them is D-dimer and another one is a tag or platelet mapping. Depends on which one your hospital is offering. The D-dimer is testing for a protein fragment that only released after a clot is dissolved. If the result is high, obviously that's dangerous, but this is not a great test for rule things in because there are many other situations could cause this, like if you got trauma. But if you got a low or negative result, you can rule things out. And the tag, I think this is a great test. So what happens with tag test is, let me just pour out my drink so you can understand easier. What happens is the blue top that you send us will be putting them into a cup, and our analyzer will have a probe that goes into this cup, and then it will stir around. Over the time, you will see the resistance on this probe is getting higher and higher. That's because the patient is start to forming a clot. And this clot holds well, and it's forming at the right time, at the right strength. You got a perfectly healthy patient able to form a clot and hold on to it. But if this clot is not forming, we will be recording a low to non-resistance on this probe. Or if the clot is forming too fast, too strong, this probe hardly moving around in there, we will be recording that data too. And the best part is, if your patient is unable to hold on to the clot and the clot is dissolving, we will be recording a resistance strength on this probe is all of a sudden getting smaller and smaller and smaller. So great test. It's called TAG or platelet mapping. Definitely go check out your test catalog. Maybe your hospital offers that.
First round of MTP is 6 units red cells, 6 FFP, 6 platelets. That's what we gave them.
Treat the patient, not the protocol. Systolic of 90 is ideal. Robbie, you could teach your residents about permissive hypotension?
Okay, we would like you to return us the blood product that you actually don't need. Okay, besides that, there is one thing, I wouldn't say that's wrong, but it just kind of outdated in the modern blood bank practice at this point. So they said they gave 6 units of each, red, plasma, and platelets. Red plasma, that's kind of standard, 6 unit, 1-to-1 for that ratio to make up the volume and maintain the hematocrit level. The problem is coming from the 6 units of platelets. There are 2 types of platelet products. One is called platelet apheresis. That kind of unit is from single donor. That's when you walk into a donation center, they will hook you up onto a machine and then only hops away the platelets in your blood. And it will transfuse you back all the other stuff in your blood, like your red cells and plasma. You'll only be donating platelets. And the 6 unit, what they mentioned in the show, means there are 6 different donors. This kind of donation happens in when you donate whole blood, and then this whole blood will later on go into a process to separate the red cells and plasma and the platelets. Each unit will be smaller. That's why you end up need 6 units of them. The biggest reason it's gradually out of practice is when you do this, giving 6 units of platelets, you expose this patient to 6 different donors, and that's greatly increase the risk of everything you can think about. So nowadays in United States, probably less than 5% of the hospital is still doing that. I couldn't imagine any hospital like Pittsburgh would be doing this kind of transfusion in real life, even in a mass casualty. Their storage is probably apheresis only.
Removing stylet. Okay, Dad, we're in. It's gonna take a minute to collect, but the fluid looks clear.
That's good, right?
It's a good sign. The lab still needs...
Wait outside. Stop what you're doing right now.
No, they're almost done.
I can't believe you went behind my back.
I did what was best for Flynn, not for you.
Take that needle out of his back.
No.
Yes.
Ma'am, I don't want to have to ask you to leave.
Take it out right now.
Yep, coming out now. All done.
Okay, this actually brings my most painful memories. Let's do this one by one. So first, when they collect the CSF, the first tube she pulled out and held in her hand was a number 2. These kind of tubes in this show for collecting the spinal fluid, they are the special tubes that designed only to collect spinal fluid. And each tube, The plastic itself will be imprinted a number 1 through 4. For the spinal fluid, to do the analysis, which tube is the first tube will be very important because the first tube will go into chemistry for analysis because it carries the least amount of contamination. In this case, they would be testing for protein level and glucose level. If the glucose level goes down, that means there is bacteria or something else is consuming it. The second tube would be going to the microbiology for screening bacteria or yeast infections, those kind of stuff. We'll be putting it on the culturing plate and do a gram stain on it. And the reason they don't use the first tube is because the second tube ensures you don't have any skin fragment contaminated into there. And the third or fourth tube, those two tubes are going to hematology to do the cellular component analysis. If there's any cells in there, if so, what type of cells? If it's neutrophils, it's probably bacterial infection. If it's lymphocytes, that's probably indicating some virus infection. And if there are a lot of cells, well, you're in trouble. So if somebody is picking up the second tube and use it at the first one, and also they did not mark or label the tube immediately by handwriting and signature change, saying, oh, I accidentally grabbed the second tube as the first tube, I write this down, I ensure this is what happens, this is in fact the first tube. All your analysis down the line could be having a huge disclaimer on it saying we cannot ensure you this result is 100% accurate or reliable. I've seen people did this before and the outcome was not pleasant. And the other thing is, the amount of fluid that she collected for the test that they want is not enough. In his case, if they need to do a send-out for screening, because most of the hospitals, they wouldn't have a full panel of different causes of meningitis screening test. They have to send it out like mail. Common things in suspicions like Lyme, they requires a huge amount of volume. So what she collected in the tube, by what I see in this show, it's probably like a 1.5 milliliters in each of the tube. Those are not going to be enough. After they do the chemistry, the micro, the hematology, and then do the send out, that's probably not going to be good. And a lot of the send outs, they don't accept the first tube, which means that 1.5 ml that she collected at the very beginning won't be counted. It's only gonna be the rest of the 3 tubes. And plus, they didn't put it in this show. Some of the tests you order on CSF, they will occasionally also require the serum to be sent together to screen for the antibodies. That's the end of the season 1, The Pitt. Do I like this show? Yes. It does create a great window for people to sneak a peek for what really the healthcare world is. Overall, great performance, great story. Although I lost my mind quite a few times watching this show from the inaccurate part of the laboratory expressions, but I gotta say, it is already one of the most accurate shows in terms of even including the laboratory part, which is kind of sad, yeah, because I've seen many of other shows that just went straight ahead, completely ruined the reputation. So, nothing to complain. Thank you for watching. This is Library Sherry. I'll be see you in the next series.